Okay, Mark. So great to have the chance to talk again about some of the key literature within the Kinetic Control story that sort of got us to here in 2025. Again, we've been sort of having this 30 years of KC narrative recently. So just going to dive into more around sort of really Sir Mottram's PhD, because I think there's some key papers in there. So I want to sort of just offer a little bit more around. But we're going to take you all the way back to just 2001 and these two publications, which I think were really seminal in getting this whole story started.
Yeah. These were the two where we first started publishing stuff in terms of the whole framework that we'd put together. And that framework started really from an integration of sort of the original leading lights of the whole movement evaluation and the quality of look at movement as quality as opposed to just empirical quantity. So Vladimir Yander and Shirley Salmon's work and how they sort of married together. And then so yeah, we started building this around sort of the stabilizer mobilizer type model that Yander and Salmon came up with. And then from there we started integrating some of the work from Queensland University that was starting with Paul Hodges and Carolyn Richardson on the local stabilizer muscles based on Bergmark's definition of what local muscles are. And so the Kinetic Control courses were probably the first courses that linked those whole processes together. So looking at one joint stabilizers, two joint mobilizers, and then having muscles that controlled and produced range of motion. And then also along with the Bergmark's and Hodges research on the local stabilizers, looking at how they have a different function of controlling translatory motion. And so we started looking at this concept of classifying muscles that way, and then that built into the process of these first two papers, looking at sort of integrating those models together and looking into an integrated framework of looking at movement quality and movement control, and linking it to sort of movement impairments that are related to pain and pathology at the time.
Yeah. So one thing that sort of sticks out with this work is the notion and also the appreciation that muscles are not the same. They're different in terms of multiple criteria, more than just anatomy. Yeah. And I think that's very relevant now when we still have problems with specific muscle injuries. And even though people say, well, the body doesn't know muscles, it knows movement. Well, that's okay, but it's still certain parts of that system that break. So there's still certain muscles that are problematic. Yeah. So having an appreciation of the difference between them is pretty key, and that's really explored very nicely within this work.
Yeah, and I think the message is all muscles are actin, myosin, and connective tissue, but they're driven. Excuse me, but those structures are driven by nerves, and that comes from the central nervous system, and the central nervous system modulates how it activates muscles by sensory inputs coming into the central nervous system from muscles and other joints as well. So I think that's where we're sort of looking at things. Yeah, muscles are not just are force producers. They respond. The information systems, their input systems as well as output systems, and the central nervous system is the bit in the middle that coordinates and controls that. And so that's where we sort of got to with the idea of movement analysis. Look, number one, defining that different muscles have different jobs, and that some muscles can do more than one job, and some muscles tend to stick to one job only. So that's a single task and multitasking muscle concept. That we probably be the first people to really push that idea. Because we made the mistake of trying to classify muscles as all as one group based on local stabilizer, global stabilizer, and global mobilizer roles that were defined. And then when we tried to fit every muscle into one box, they didn't fit. So that's where we started realizing the muscles are way more complex. And then some muscles do more than one of those roles. And that again is controlled by the central nervous system. And because it's controlled by the central nervous system, we can influence that. We can train the central nervous system to look at these muscles in different roles. And then, number one, we have to measure what they do and what they don't do, and when they're not doing when they're not doing that efficiently. And then we can look at retraining that. So that's sort of the whole process of where the ball started rolling.
So that iteration then of the model, going the initial idea of this sort of single role, which then, we need to break the model to find a new model, which is then what happened with the idea then, the ability to multitask And I mean, I would venture that some of that multitasking is some of the reasons that we have particular problems in specific structures.
Oh, hell yeah.
Yeah. Okay.
Exactly.
Yeah. Okay.
Yeah.
And also very nicely, you're talking there about beyond force production, beyond the ability to generate motion, but also the ability to sense motion and to be a sensory component of the system.
Yeah.
So it's the interaction between, I guess, the environment of being able to sort of sense the environment, perception, but also then motion that comes from that. So that's, again, very relevant, I think, in terms of how people are thinking about now how we organize ourselves on the planet with respect to moving around, that we need to also sense as well as move.
Yeah. And I think that's where sort of the complexity starts to sort of get really interesting. We think of muscles as doing different jobs, and some of them can multitask some of those jobs, and some of them single task only one job. But then in terms of any one particular movement in any one particular direction, they're synergists. So muscles work in groups, and they all three different muscle roles work at the same time to produce movement at any one joint. But then we've got to move at more than one joint at the same time. So how some of those muscles will act across two joints, and then so we've got synergists are working across one joint, all working together, and how they coordinate together is varied from task and environment as well, and within the individual. But then we also then have to come down looking at the multi-joint system. So how do we control one joint while we move another? Are there restrictions that create compensations for that? Is there is there fear avoidance and guarding protective strategies that change the way we move? And so once we change one factor in the domain, then we've got to make adaptations in multiple ways in other joints and other factors as well. So it's a complex system, and we're starting to really not understand the crazy detail of it, but we can understand the functional and the practical implications of it, and that's what we're starting to get good at.
Yeah. Okay. So very nicely there, Mark. You're moving into sort of complex adaptive systems, a very contemporary view there. So let's again sort of move on to that in terms of some of the work that's in the PhD, because then that does touch on that more.
Yeah.
So what I've done is to pull up what described as the 5 core publications that make up the PhD, and I think we've contributed in different amounts to this as well in terms of these publications. So we won't talk about all of them in massive detail. They're out there in the world, and they're also in the PhD. But just then, let's just go around just to, I guess, the 2015 reliability paper for the performance matrix. And I know you were involved as one of the individuals doing the rating on this.
Yeah, that was quite an interesting paper, because we for the whole framework of looking at movement from a kinetic control framework, we're looking at sort of like controlling one joint at a time in particular. Where's the painful joint, and what's looking at that from a performance point of view. Multiple joints work in multiple combinations. So that's where the foundation matrix came in, and what we were trying to assess there is previously there'd been shown good inter and inter-test reliability of assessing one joint at a time. Can you control one joint in a certain direction while you move somewhere else? And that showed it was reliable and repeatable. And then within the matrix, where we're looking at sort of an integrated movement, a multi-joint movement, and then can we look at that across what's happening with that as well, and look at controlling more than one direction, more than one joint at a time. And what we did show there is that people who were considered to be experts, so people who had lots of experience at assessing these movements, had very, very good intra and inter-tester reliability. But what was really so that was good to say that we could see that, and we can qualify that within our assessments. But then also showing that novices, people who had sort of a structured training program but weren't particularly experienced, but we could teach novices to evaluate this, and novices also showed surprisingly quite good intra-tester reliability and reasonably good inter-tester reliability in terms of looking at this in a much more complex way.
The points there, Mark, are the element of threshold. Now, I still think this is hugely undervalued within testing approaches. That there's rather generic movement quality batteries out there that have not recognized the value of having this stratification of threshold. Now,
Yeah.
I guess when what we've done and what you guys have developed and been talking about for so long, it just seems it's almost sort of implicit in how we're going to think about things. But this is not widely recognized still. So just again, something around threshold in terms of the value of that.
Okay. So threshold is sort of, low threshold and high threshold is what we're talking about. So we've developed these tests which we consider to be tests of low threshold control. So these are movements that are relatively mainly used in the domain of postural control, non-fatiguing activities, non-fatiguing functional ranges of motion. So which are predominantly in the range of slow motor unit recruitment ranges. Okay, and so, but they're the things that are functionally relevant for postural control, being able to maintain alignment position over time without fatiguing out, and maintaining control within our functional non-fatiguing movements. And so, low threshold is not just low force. Low threshold is about sort of, can we maintain a control level through a certain time frame without fatigue and good control and coordination. And then high threshold is sort of the other dimension, which affects performance in particular. Is we're looking at sort of, as we increase load, the central nervous system, and as we increase force, requirement of force, the central nervous system recruits slow motor units predominantly to start with, but then has to add in fast motor units, so the fast fatiguing, high force producing motor units as we add load and add speed. And so high threshold is something that we sort of focused on as being, not just about maximum force, but is shifting across the boundaries of not just slow motor unit recruitment, but fast motor unit recruitment as well, associated with increasing resistance or load, but also not necessarily just load, but speed. And when the central nervous system plans to do a fast movement, it will recruit fast motor units to a large extent, even though there might not be particularly high forces involved. So we developed this concept of low threshold tests for postural control and non-fatiguing functional movements, then high threshold tests. Are looking at sort of putting in a challenge for the central nervous system to have to drive fast motor units along with slow motor units in its activities, and consequently these motor units will fatigue out. They burn glycogen, so it's the limited supply. And so as we fatigue, how well can we maintain this control, and how efficiently can we maintain control under elements of increasing fatigue loading, but also in terms of fatiguing fast movements.
The sensory component of threshold as well is that I would see is that under a low threshold stimulus, for example, there's less proprioceptive guidance to how to perform that action. Whereas when we start adding a load component, we start getting more of a stencil around how we move, as it were. So for some people, they need that stencil of loading to be able to sort of coordinate the movement. Or if it's speed even, that they've got, again, that sensory input, which they may not have under low threshold. So if they can't perceive, then they struggle to move in the way that these tests require. So there's that element within this.
And that's another interesting point about that, is that in the presence of pain, people can still generate force generally, unless they've got significant structural injury. Okay, but as we increase load and force, that's the biggest sensory input. So some people actually do well if they can add loads because they can feel a sensory input. But what we find is that in the presence of pain, and particularly persistent pain, people will find it difficult to pass the low threshold tests because they don't get enough stimulus for the central nervous system inputs to be able to provide control of movement. So it's not just that the high threshold tests are a progression of the low threshold tests. Okay, the low threshold tests different things. The low threshold tests take away the stimulus of load, and then can your central nervous system pick up enough sensory information to provide control of movement in the absence of load providing a stimulus? So the whole idea is that we don't want people to get the idea that we start with low threshold tests and progress to high threshold in the traditional concept of strength and resistance training. The tests evaluate different parts and different problems within the whole sensory motor system.
Yeah.
So there are people out there who pass a multitude of high threshold tests but fail a low threshold. And vice versa.
Yeah, that sensitivity, the motion, the movement occurring is key and is inquired into through that particular process. And again, I just don't see this enough out there. Anyway, there's opportunity around that. Okay.
Yeah.
So now in 2018,
and our training systems focus on that too. Focus on that differentiating those processes as well.
Yes, of course. So it's not just the testing; it's then what you do about it once you've you found out there's a problem. There needs to be then an appropriate fix.
Yeah. So yeah, once you've identified the problem, what are we going to do about it? And we come back to some of the neurophysiology of our retraining behind that as well. And low threshold retraining might be different to high threshold retraining.
So I'll come to that, and then the 2019 paper, very nice. So now 2018, we see 2 publications. Busy year for everybody here. So what we see then is the more the anatomy-driven study around serratus. Now serratus, Mark, just sort of broadly, in terms of sort of classification and roles for this particular structure, what would you sort of be? What would be the big hitters there?
Yeah, well, see, that was an interesting muscle. A lot. There's along the lines of that. There was a lot of work on serratus and also on trapezius. But the serratus study was really quite interesting because it's a muscle that wasn't often very well evaluated, and so it has an element. It produces a multitude of movements. It produces protraction of the scapula, but also produces upward rotation of the scapula. And then it also has an element of providing thoracic and rib control because it attaches to the thorax and ribs. So if the arm is closed chain, then it produces thoracic movement as a consequence. If the arm is open chain, there's scapula, a combination of different scapular movements there. And even the most superior, deepest parts of the scapula, which are deep underneath the scapula and coming off the upper ribs, they're almost vertical. And so they're basically just holding the scapula up against gravity. And that's where we start to think that maybe we know that the majority of the serratus anterior is a global stabilizer muscle that produces, it's a rotator of the scapula. It tends not to have the mobilizer role, but we think it also multitasks the local stabilizer role as well within that pattern.
Beautiful. I always like the conversations we've had around serratus as a rotator for the thoracic. So then working as a synergist to the obliques, and sort of when we look structurally, we can see that that's logical. It makes sense in terms of a positioning, but I always like this idea that once you sort of fix the arm, you could play this rotation role. Yeah,
and its fibers interdigitate with the external oblique, so effectively they're sort of linked muscles. So basically that serratus anterior, once you've got the hand as a closed chain point, it coordinates with the external oblique abdominals as providing, number one, the ability to move the body around the weight-bearing or the closed chain arm, but also its neurophysiology and its biomechanics working with the external oblique. So it's producing rotary control of the thorax and the pelvis because the external obliques go right across to the pelvis as well. So entire trunk control.
All right. So now we move into more of a conceptual paper with the assessment of movement health in clinical practice. Now, multidimensional perspective. This was the collaboration with the authors who were taking more of a observation of preferred, if you want to call that, self-organized movement. And we were then coming in with this idea, alongside sort of self-organizing movement, you've got to also consider the conscious control of movement and bringing these two elements together. So, you can have preferred movement, just watch somebody do a task, no cueing in terms of how it's done, plus our approach, which would be much more focused on the execution with specific questions asked around the execution. And this included the dynamical systems model with a view that it's a complicated system, a complex adaptive system we're trying to deal with. And we arrived at this idea, well, if we can assess something that's called movement, that is the product of that interaction of these different domains, then that's useful. And also we can modify this output and send this output into the future for the next set of interactions. So it was a way we were trying to say, well, how do we use what's out there to try to manage the clinical environment to assess this thing called movement health?
Yeah. And so that was quite interesting because, there'd been a belief for a long time that if people had inefficient biomechanics, so they might have jumped and landed with the foot turned out, or the knee coming into a valgus pattern, or they might land in with a lot of lateral trunk compensation displacement. And I think one of the where a lot of this came from is that a lot of coaches and a lot of people have been trying to retrain those what they might be described as inefficient biomechanics or disadvantaged biomechanics, and just getting people to try and correct their alignment and correct their landing alignment, correct their trunk alignment. And for some people that was an easy fix, and for some people it was an impossible fix. No matter how hard they tried, they could work at that. And so our hypothesis is that, you know, sometimes it's because they can't coordinate the muscles that they need to control those movements. And so that's where this paper sort of looked at sort of from two sides of things. You know, like within a sort of a pattern of movement, do we have the ability to coordinate the synergists and change the interaction of the synergists to correct movement? Okay, or is it simply just a pattern that they've got a bad habit, they've got poor biomechanics, and then as we can get them to realign that? And so that's where these four subgroups came on. We found people who had, you know, a combination of good biomechanics. Naturally, they had good alignment and good biomechanics, and they had good motor movement control components, cognitive. And we could test those things by looking at, can you give them an instruction to land in a certain way, or can you give them instruction to pass a cognitive movement control test in a certain way? So there's one subgroup of people who had good biomechanics naturally, and their motor control or their coordination control was also good. Then there's other people out there who had poor biomechanics, but they struggled that because of the way that they moved, but they passed movement control tests. So they're the people who just needed more coaching, and they're the people who needed more skill development. And then there's another group of people who actually had, they naturally had reasonably good biomechanics, but they kept getting pain, or they kept getting injured because they couldn't control it in dynamic situations, or in changing environment and changing task. So in one task they might be okay, but another task they might not. And so by looking at by assessing them, we could find that they failed movement control tests, cognitive movement control tests, even though their basic mechanical wasn't too bad.
So where we end
also
up
the fourth subject.
You go for it. Sorry, Mark.
Yeah, and then there's the final group who had poor biomechanics and poor movement control, and they're the people who really struggled. Yeah, they're the people who had a history of recurrent injuries. And what's that we see now is that they're people with recurrent injuries, and they're very hard to control because we need to look at their biomechanics, and we also need to look at that, and that's got to be trained in tandem. They have to work together.
So with that, then we arrive at a model where if you're going to use this self-preferred, self-selected type approach of looking at how they move, but not questioning how they move, but also then combining that alongside the ability to question how they move to see whether, if we're going to make that decision to change how they move, do they actually have that coordinative ability, yes or no? And if they don't, then that's going to be really hard to try and go and change things in multi-joint actions such as this.
Yeah. So I think the idea, the ability that we can assess both of those things independently, and then work on, so if you don't have the ability to cognitively control the movement that you're going to have to try and retrain, then it's not a bad idea to do a bit of that as the building blocks for the skills you're going to retrain in terms of your biomechanical retraining and corrections as well, or technique and skill training, as we might sometimes refer to it.
Yes. And now all of this, I think we have to put the caveat in that ideally this is done on an N=1 approach. Therefore, we're not saying that the within the part of the model where there's the optimal so-called biomechanics, it's for that particular person with the constraints they're under, as the model suggests, what works for them. And for that person, have they lost specific choice in how they move? Well, we need to know that. So we're going to help them with that particular thing we're trying to change if we've made that decision to do that. Not that we're trying to make everybody move in this same particular way, because we think that's pretty flawed as a model. Yeah.
And I think that's where there's a lot of overlap in terms of looking at this, and again, it is very N=1. You can't look at someone play a sport, or you can't look at someone in a skilled movement, or in their functional movements, or a sporting movement, and say this person needs biomechanical correction, or this person needs movement control correction. The idea is that you have to pull them out of that and look at those pieces of the puzzle, and then work out where what needs work on, and then put them back together, then integrate them back together to get to the final result of a efficient functional movement or efficient sporting skills.
Yeah. And I was thinking there that N=1 is quite a nice idea with respect then over time, even that person's not the same person because they change, they evolve. And again, that's included in that particular model of them changing over time. And actually, if they move the same all the time, that actually might be problematic in terms of that low variability story.
Yeah. And so I think that's one of the things about the variability is that, variability we know is good to manage pathologies or to decrease the risk of injury. Okay. But also from a performance point of view, there are certain sports where low variability is an advantage. Like in a golf swing, you don't want a lot of variability in this multi-joint movement. In a tennis serve, you don't want a lot of variability. And so people who are train these things, will train the variability out of a particular technique. And so more dynamic sports like soccer or football or, so something else where people are becoming more active, like volleyball, for example. There are multiple movements, so training variability out is not an issue. But there are sports out there where precision is a high thing. And so, for example, someone who does a long jump doesn't want a lot of variability in the way they leave that board every time. Someone who has a golf swing or a tennis serve, they don't want a lot of variability. There are subtle things they'll do to put top spin on it or back or a bit of spin, but the basic skill is the same. And so training variability out for a certain technique is an advantage for performance, but it's a risk for pathology. And so we've got to start balancing that out with people again too.
So performance doesn't equal health, and the location of where we're looking at for variability really matters. So are we looking at the end point where the club hits the ball, or are we looking at actually how this person needs to articulate multiple regions to make sure that consistently they can achieve that end point low variability? And that's going to vary across different sports. Okay. Now that takes us very nicely then into a sport, which is rowing. And this is the 2019 paper. Now what happens here? So for the N=1 approach is adopted. It's the performance matrix is also adopted. So it brings nicely some of the ideas we've talked about already here. So the athlete is tested performance matrix early, so before an intervention, then post intervention. Now they're presenting with a particular case around the hip, and the outcome of this is that following this, I think it's 16 or 17 weeks intervention, that there's a large change in the performance matrix scores, as in they now can express more choice in how they move, both at low and high threshold. But there's also changes in the kinematics of the hip, how the thigh coordinates with the pelvis. And there's also change in terms of range of motion. And importantly, there's change in terms of Hager scale, so outcomes, clinical outcomes. So improvements across the board through an intervention being steered by performance matrix retraining.
And I think the interesting thing there is that, by doing an evaluation of these multi-joint movements, so the whole idea is we can look at sort of how not one joint works at a time, but how that works in combination with its teammates. And then that's what the matrix does. It then looks at low threshold inefficiencies and high threshold inefficiencies. We can then make decisions about how, for this person, they've got a hip pathologies going on. So which of those inefficiencies that we find in sites in different directions, the matrix will find that, but not all of them are relevant to the hip. So then we make clinical decisions on the N=1, that this person, how many of these problems that we might have found are relevant to the hip. We're going to focus on those ones, and then look to see what effect are we having. What effect are we having in terms of looking at our treatment interventions to change that? And so we don't just repeat the tests we failed as the treatment. We actually do. It's much more subtle than that. We look at specific strategies to control the things that the test has identified and regain movement efficiency of the tests that are identified. But then the outputs of the outcomes of that are that we change the way the hip naturally moves. We change the way that we find on rescoring our original tests. So we're getting more movement efficiency, more movement control. We're changing symptoms in pathology, and we're also going to try and look at, are we actually changing rowing performance? So the things that we're looking for is based on an evaluation. Okay, we then look at targeted retraining based on that, but not just practicing that test till you pass it. That's a very naive way of looking at it. So we actually discourage people just practicing the test you fail, but we look at sort of like what are the implications of the test you fail? What muscles do we need to train? What joints do we need to provide control of? Are there restrictions to mobilize? For whatever we can interpret from that test. We then retrain those things. We build it in there, and we're looking for outcomes in terms of changing the way the joint functions, changing the way the joint feels symptomatically, okay, changing the way that we can pass a retest without actually just practicing the test. So we start showing that we are changing evaluation parameters, and also are we able to change performance markers. So those 4 things are things that are valuable things to change by coming back to a basic screening program, and then looking at a clinically directed program based on the individual and how we interpret the tests that they have problems with.
So the idea would be, if you failed tests of choice, is that you've lost choice. Therefore, if you need to explore let's just say the idea of a movement landscape, so you're going to problem solve by finding different solutions to given movement problems. But if you consistently arrive at specific solutions all the time, or certain solutions are off limits, then we would see that's problematic. And the idea of then the retraining intervention is to give you more ways to solve the problem. And that's not the same as just being able to talk how to pass the test. That's a very distinct, Okay.
I think that's an important point to make, is that, if people fail a test, by practicing the test, people can pass it. That's an examination procedure that people have been using since time began.
Right.
But doing that isn't necessarily going to give us the outcomes we want. So we've got to be a bit more clinically smart about how we are going, clinically savvy about what are the interventions we're going. But that's partly what, within our whole framework of teaching courses, is we teach people how to make those clinical decisions. You've got a test. Okay, how do we interpret that test? Now, what are we going to do about it? You don't just practice the test. You've got to look at sort of the underlying things that test. If someone fails a particular movement control or movement coordination test, what are the implications of that? Is there a particular muscle that's not doing its job? Is there something working too much? Are there restrictions you're compensating for? Are there psychological factors that people are being guarding against? There's a lot of stuff in there. But that's what we try to teach within the framework of the work we do, and that's evolved over 30 years now.
Yeah, indeed. So then the 2020 paper then takes on the previous work and offers somewhat of a summary at that particular time. The new elements here are this really sort of working with this idea of the term uncontrolled movement, and progressing or changing at least to this loss of movement choice, with a view that just because how the testing is conducted, that we believe we're testing choice in how somebody can problem solve. And if they don't have that choice, then that choice is lost. And then also the other factor here was the idea that we believe variability in movement is worth exploring, but that's very difficult to do clinically, or has been. We'll see what Marcellus does for us. But if we've got a clinical way, a qualitative way to inform on movement variability, we believe that's valuable. So one of the things here was suggesting that a loss of movement choice was a qualitative means to inform on reduced variability in movement, that consistently somebody's adopting a specific strategy that has become invariant, that they gravitate towards, in the dynamical systems language. It's an attractor, that they fall into that well. And this is one of the reasons that the tests would start in a mid position as opposed to an end range position, because we need to see that if they're going to fall into a particular pattern of motion, and when questioned, that they can't stop doing that. So that was one of the key things to come out of this one.
Yeah, and I think one of the elements of that too is that there's no one test. Okay, so if someone's got, for example, hip pain that's provoked by flexion, or back pain that's provoked by flexion, or neck pain that's provoked by extension, or shoulder pain that's provoked by an abduction movement of the arm. Okay, so we've got sort of a link in terms of, okay, there's a movement that hurts and it hurts here. Okay, and then so how do we test the variability? There's multiple ways that you can lift the arm. There's multiple, and coordinate the scapula and the glenohumeral joint and the trunk that it all works from. Or there's multiple ways that you can flex the hip by by moving the hip and then moving the pelvis and then moving the spine, and what happens to the weight-bearing side versus the non-weight-bearing side. They're all variability parts of this whole equation, and so there's no one test that can test that. And so the whole idea of tests of variability is that we've got to have more than one test of the same site and challenging it with, can you control the same direction? So if you've got flexion provoked symptoms at a certain joint, can you control flexion at that joint, but in multiple different ways of evaluating that? So can you control flexion while you move above? Can you control flexion while you move below? Can you control flexion while you move on the other side? So the whole idea is that there are multiple ways that we can challenge the ability to control that flexion. And so by building a battery of tests, and so I think this is the other part that we need to make very clear too, is that there's no one test of cognitive control. There's no one test of movement choice. Testing movement choice is testing more than one way to do a similar movement control strategy, or a movement coordination strategy.
So we're going to talk about sort of movement invariance. We need to have the ways to check it repeatedly. So one trial is not enough, and probably one test, as we're describing here, is just not enough. We need multiple challenges to see if they can problem solve, and consistently, if they can't, we would be then more confident in arriving at this idea that they've lost this particular choice. The invariant motor behavior has been displayed, and ideally then through the retraining, to build out more choice, to have the ability to explore more ways to problem solve, which we would see if they don't have that is problematic.
Yeah, and then by evaluating the control of cognitive movement, alignment, and coordination, or looking at a set of valuing, do you have the choice to move in this pattern versus that pattern? And so when we find people have got pass one of these tests and fail another one, there's no point getting them to practice or practice the one that they're already good at, because that strategy is already within the central nervous system motor planning and motor coordination. And so, but the idea is that the ones that they can't do efficiently, but that other people can, is evidence of a loss of choice. It's evidence that they've lost this part of variability that other people have, and that we want to bring it back for them. So then we will work out ways to retrain that back, recover that choice.
I've got into the habit of during a test, if they can pass it, I also then say, well, can you also show me the fail? And that's great, because now you're showing me that you've got more than one option, not just the pass option. You've also got the fail option, and they can do it at will. And the people that fail can't do that.
No. And clinically, that's one of the things I demonstrate all the time to patients, is that, what I'll do is that I could look like. And if they can understand, if they can't feel it, then put your hand here and so you can feel what happens. Okay, and then what I'll do is I'll demonstrate how to do it wrong, and this is what you just did. And so and that's part of the thing, is that if you can demonstrate the fail as well as the pass, that's you get bonus points for that. Well, you should get bonus points for that, because it shows that you've got multiple options of not just the variability of control. Okay, but the variability to change the control in maybe what we might consider to be a disadvantaged way biomechanically, possibly. But it's just that, yes, that's not necessarily going to be a disadvantage unless you're stuck doing it all the time. So you even if we can demonstrate, there's no such thing as a bad movement. All movements are valid. Okay, and the idea is that sometimes what you might consider to be a movement test fail is an inefficient movement for that person. But it's not necessarily a bad movement. There will be, going back to the movement systems model. There will be times when that movement is an advantage for a certain situation, for a certain task in a certain environment, and it might not necessarily be by something that's biomechanically advantageous to do often. But the ability to do that is a performance marker that you can do it when you need to, and even though it might be biomechanically stressful, if you don't do it a lot of times, it's not going to cause a problem.
Yeah, it's the conversation about, is it the shape or is it the frequency? So it might be both, but but we certainly feel the frequency of a particular action, of a single action, is again a bit of a problem. Is it the particular shape? Well, we can debate that around the biomechanic component. But if you get the component of well, maybe this is not the best shape, but also it's done in a frequent manner, that might be sort of the worst of both worlds if we believe, again, that the shape is a bit of a problem. Yeah. Okay. So just going to then sort of bring that to where Sarah's PhD sort of arrives at with one of the outputs of this, which is the infographic.
Yeah.
And what we have then is this movement coordination strategies and this sort of approach of assessing, moving into interpretation, which I think you've very nicely described around this idea that, well, how does it relate? How does it have meaning for this person with respect to a presentation, or is it about performance? Is it about, again, some sort of limitation on participation? We then want to get into the retraining component of restoring. So I guess the optimistic component of that is believing that they had it before, we can restore it. Maybe they didn't, but adding it into their repertoire of how they can problem solve would be great. And then we circle back around with this sort of the loss of movement choices associated to then the movement coordination strategies.
Yeah, exactly. And I think the starting point is that the assessing for these using cognitive movement control tests to find that loss of movement choice, the loss of variability in a particular site in a particular direction, for example. But then it's not just simply find the test you fail and then practice the test until you pass it. There's what is the relevance of that? I think is an important part there too. So how do we interpret that? In terms of in terms of that person's in the individual sort of, so in terms of their pain, pathology, the things that they want to do, the things that they need to do, performance markers, and then also mitigating the risk of injury. So that's one of the things where I think there's quite a bit of future here, is that there are ways that people move that put themselves at risk. Now, there's lots of things that mitigate that risk. Sometimes you're just tough. You're born with tough connective tissue and you can last longer. Sometimes that risk is never put under significant load or challenges. But sometimes that risk, but in a variable environment, that risk becomes greater. But then also the idea that finding things that we might consider poor quality movement or inefficient quality of movement. Okay, what is there value about making it better? Is there value in restoring a choice that they didn't have before? And that's where there is a bit of debate. There's no significant, definitive proof here, but there's a very compelling argument that, if there are risk factors that people who already have pathology and injuries have, when they've got pathology injury, they have these movement control impairments, these inefficient movements, these lost choices. Okay, if we see this in people with the injuries, and we see it in someone who doesn't have the injury, and they're playing the same, they're in the same environment, playing the same sport, for example, why not do something about changing that factor? Because one, we might be able to prevent injury, but also two, if they get the injury, they're probably going to go down the path of trying to have to retrain that anyway, like the people who've already got the injury. So we get them ahead of the game. But and I think that's where some of the stuff where when in the early days of developing the matrix, there was stuff out there showing that in some of the sporting teams that by putting in a program, looking at these risk factors, and then getting people to fix the problems they had, even though they didn't have injuries. There's anecdotal evidence that, and some measured evidence that they can decrease the injury incidence compared to previous years when they weren't doing this. But that data's slow to collect, and some of that data is company
proprietary, I guess, within teams,
with the performance, But there's a lot of interesting stuff out there, but then interpreting that gives us a strategy of where we want to go, and then we can then retrain that, so we can then reassess that we can do with the restoration work we're doing. We can then reassess by how well we've done a good job at reassessing the tests we failed before, and then looking at what does change in this movement quality and quantity affect, So are we affecting some of the things that we went through that interpretation before? Are we changing pain? Are we improving lifestyle? Are we recovering activities that people want to do? Are we looking at sort of improving performance? Are we able to decrease risk of injury? So they're things that can be evaluated as a secondary component of looking at, well, what are the effects of having us done that interpretation, and then the restoration work, the retraining work.
Okay, Mark, well, that's excellent. So thank you for exploring this. I think we've got a whole another insight on this particular part of the literature and Sarah's work here.
So in summary, like over the 30 years, we started off with a really basic process of a bit of the stabilizer mobilizer model of Yander and Salmon, and then adding in some local stabilizers as that research developed. Then we got a lot more subtle. We looked at the model, classifying muscles as a movement, functional roles of muscles as they different possible roles. We found some muscles could multitask some of these roles. Some muscles were single tasking it. Then we started putting it into an integrated framework of looking at like what we now call cognitive movement control test, looking at, can we identify, can we match the site and direction of pain and pathology with the test we pass or fail. And then we looked at sort of then specific muscle retraining of those different muscle roles that might link into those tests we fail, and then putting that back into framework. And that's moved on further from that. So our process started with just managing pain, and now we're looking at sort of performance in the absence of pain. We're looking at sort of movement mentoring, and sort of looking at movement efficiency as a model, as opposed to just pain as our model. So it all started with pain and pathology, but now it's moving into more movement as a whole, and looking at the whole idea of movement health as a improving quality of life, movement efficiency, and then also maybe mitigating the risk of developing pain and pathologies over time. Joints wear out because we've got stressful movements on them, and then identifying ways that we might be able to slow that process down as we get older. We're all going to live longer, and well, theoretically, and then so we're all going to live longer, and we want to sort of make sure we can enjoy those years. Without running out of function.
That's it. So years in your movement and movement in years. So it's the independence in how you again get around the planet, that movement lifespan idea, the ability to change movement if we believe that specific patterns are associated with the aging process. Well, if we can assess that and change it, then we're doing something to offset that particular change over time.
And what's really good to see now is that we developed these processes from a theoretical framework. And then, one of the things that when we started developing the kinetic control framework, one of the things that Sarah Mottram in particular was very strong at pushing forward is we've got to find some evidence, we've got to find some research. And so we tried to find other people's research to support it, but then also we started doing our own research to support it, which has culminated in Sarah's proof of concept PhD on the health of movement, recognizing movement choices in individuals for long-term health.
Exactly, and that's acting as the legacy of this is now acting as stimulus for future research, and it continues. So we will look for more ways to support this particular movement message over time. And as we say last time, part of the next 30 years of Casey. Exactly. Okay. All right, Mark. Well, thanks for that.
Okay, thanks, Lincoln. Okay, that was quite a good insight into sort of how it's being developed and supported.